Hello everyone. In coming 10 minutes, I will present the IAPEN guidelines, the Nutrition Consensus Guidelines in Oncology Clinical Practice. It was published on 14th March 2022. So these are the sequence of presentation. I will start with introduction, methodology, screening, recommendations of each nutritional components, types of nutritional interventions, specific interventions in different scenario, role of MDT, and conclusions. Well, malnutrition in Indian patient is prevalent. It is as common as 80%. Malnutrition is associated with poor response, higher toxicity, and more complications. Screen, assess, and intervene may prolong survival and improve quality of life. Indian scenario is different from the Western scenario in that we have more predominant vegetarian diet and we have more of head and neck cancer patients. So the guidelines is intended to bridge the gap between the existing guidelines and the Indian scenario. Well, in the guidelines, there is basically a critical evaluation of IAPEN, Spanish and AACR guidelines. So after this critical evaluation of these guidelines, the unique factors specific to Indian scenario were addressed. So after this, several rounds of deliberation were done and a final draft was circulated. Nutrition risk screening and assessment has to be done in the first visit itself, and it should be done at baseline and periodically. Patient-generated subjective global assessment is a recommended way of nutritional screening and assessment. Other ways are performance status and DEXA scan for bone health, CRP and albumin for inflammatory markers may also be considered. Coming on to patient-generated subjective global assessment, it's an online tool which is available. It includes various parameters, including weight change, change in diet intake before the onset of, before the diagnosis of cancer, and then GI symptom, functional status, physical examination, including edema, ascites, fat, and muscle mass. All are considered. And after assessing all these parameters, the severity of malnutrition is classified into A, B, or C. Coming on to recommendations for individual nutrition components, the recommended energy requirement is 25 to 30 kilocalories per kg per day. It has to balance with the resting energy expenditure plus diet-induced thermogenesis plus physical activity. Protein requirements is 1.2 to 1.5 gram per kg per day is the recommendation. Many, however, find difficult to meet these requirements. Brand chain amino acid supplementation, the evidence is inconclusive. Carbohydrate and sugar intake, the recommendations and the definite evidence is controversial. It indirectly impacts recurrence and survival. The guidelines recommend limiting foods high in starches, sugars, fat, with a corresponding increase in protein, fiber, and micronutrients, but not beyond the RDA. Prefer complex carbohydrates over simple carbohydrates. Fiber, the recommendation is 40 grams per 2000 kilocalories per day. Fiber supplementation or fiber intake reduces mortality in colorectal cancer. The hazard ratio is 0.78 for colon cancer specific mortality and 0.86 for all cause mortality. Antioxidant supplementation, there is inconclusive data on its efficacy. It may even interfere with the efficacy of chemotherapy and radiation. Worsened outcomes in breast cancer is documented. Therefore, antioxidant supplementation should not be used routinely. For probiotic supplementation, there is some evidence to have protective effect on radiation-induced diarrhea, colorectal cancer, and stem cell transplant patients. However, the data are insufficient to recommend its routine use. Micronutrient supplementation. Vitamins, minerals, trace elements should be supplemented as per the RDA. Random high supplementation is not recommended. Individualized diet counseling improves quality of life. Oral nutrition supplementation is more effective in enteral nutrition. In a meta-analysis of 11 studies, where omega-3 fatty acids plus polyunsaturated fatty acid plus high protein diet in patients undergoing chemoradiation, it maintained body weight with no effect on toxicity or survival. Supplementation with vitamin C, D, E, selenium, and calcium routinely, doesn't have significant benefit on cancer outcomes. Types of nutrition interventions include oral diet, oral nutrition supplementation, enteral nutrition, total parenteral nutrition. And they prefer oral or enteral nutrition in a functioning gut. Coming on to specific interventions. In surgery, in patients who undergo surgery, there is a catabolic state where there is both malnutrition and loss of lean muscle mass. Therefore, the intervention should have both nutrition plus physical activity. Therefore, the ERAS protocol, that is the Enhanced Recovery After Surgery protocol, has two components. One is nutrition intervention and early mobilization. So a pre-op nutrition assessment has to be done, and the duration of pre-op nutrition intervention should be in the range of 5 days to 14 days, depending on the severity of malnutrition. If there is more time required for nutritional well-being or nutritional intervention, the surgery may have to be delayed. Immunonutrition with arginine and omega-3 fatty acids may be considered. Oral feeding and mobilization on the first post-operative day itself is recommended as per the ERAS protocol. Therefore, early initiation of nutrition, oral feeding, and early mobilization is recommended on first post-operative day itself as per ERAS protocol. Radiotherapy, individualized patient counseling is important. Early intervention with oral nutrition supplementation and/or with enteral nutrition is recommended. Enteral nutrition in those patients who undergo rice tube feeding, in them maintaining swallowing function and speech function is important, even though there is enteral nutrition going on. In patients who undergo chemotherapy, there is a higher nutritional requirement. Omega-3 fatty acids or fish oil may improve appetite and weight, and it may be protective for peripheral neuropathy. In patients with stem cell transplant, parenteral nutrition has a definite role in patients who have severe gut GVHD or in patients who have severe mucositis or diarrhea. A neutropenic diet is preferred. So, in cancer survivors, obesity metabolic syndrome is more common and is associated with increased cancer recurrence. Lifestyle modification with physical activity and maintaining a BMI between 18.5 and 22.9 kg per meter square is recommended. The diet should be high in vegetables, fruits, and whole grains, and it should be low in processed food, saturated fat, refined sugar, red meat, and alcohol. In palliative patients, there needs to be an understanding of change in the objective The change is from aggressive intervention to more of a comfort care. It has ethical and legal issues involved. Therefore, a frank discussion regarding the goals, preference, and expectations with the patient relatives is important. Also need to explain the routes, frequency of administration, and composition of nutrition has to be explained. Well, aggressive nutrition and hydration has limited role in palliative care patients. Well, MDT has a definite role in oncological management. However, in nutritional management, MDT has a role on a case-to-case basis where you need involvement of multidisciplinary approach. For example, in a patient who is with head and neck cancer receiving chemoradiotherapy, along with the radiation medical oncologist or surgeon, you may also need you need a dietitian for prescribing a proper diet, and to implement you need a nurse, and then you need a occupational therapist or a speech and swallow therapist for maintaining the function. You need a physiotherapist for maintaining physical activity. You need a psychologist and a social worker for comprehensive care. So to conclude, malnutrition is a major issue in the Indian scenario. Screen, assess, and intervene are the integral parts. Early enteral nutrition reduces the risk of malnutrition in specific scenarios. Balanced diet, rich in protein, phytonutrients, fiber, antioxidants, and less in saturated fats and refined sugars is recommended. MDT has a definite role. So with these measures, there is an improvement in quality of life and treatment outcomes. Thank you everyone for patient listening.